Now, last but not the least, it's my proud privilege and great honor to introduce Dr. Vishal Mehta, who is a good friend of mine, who is currently working as specialist pediatrician in RAK Hospital. He did his basic MBBS degree from Jawaharlal Nehru Medical College, Belgaum, Karnataka, India in 2002 and MD Pediatrics from the prestigious PGI Chandigarh in 2006. He is a pediatric advanced life support instructor and is proficient in clinical skills, pediatrics, neonatology, and all other subspecialties. He is well researched and is a guest speaker in many national and international conferences. Today, he will be taking us through a very relevant topic, influenza in children. The floor is all yours, Dr. Vishal.
Thank you, Dr. Subhranshu. Thank you for your kind introduction. The topic today I'm going to discuss is something which is very common and what we see in pediatric patients in our day-to-day practice. Can you see my screen or?
Yeah, it's okay. No, again, you can share it.
Yeah.
Yes, you can make it full screen, Dr. Vishal.
Yeah, because I'm not able to see the screen. Just give me a minute. I will just open the screen.
Sure. I think once you share, below there is just a click for full screen.
Yeah.
Yeah, right.
Yeah, now you can see my screen. Yeah, thank you.
Yeah.
Thank you very much.
Welcome.
Yeah. Thank you very much, Dr. Subhranshu. Quickly, I will start with the topic today of discussion, that is influenza in children. Now, let me start with a simple case scenario. We have a 5-month-old child. We have a 5-month-old child with a fever of 5 days, cough and cold for last 3 days, and has a breathing difficulty for past 2 days. The routine investigations were sent, and the child was started on broad-spectrum antibiotic. The fever and distress is still persisting even after 3 days of admission to the hospital. On examination, the child has normal CFT, temperature of 38, heart rate which is slightly increased, 166, breathing rate of 68, which is now a bit increased for the age. Oxygen saturation is 96% on room air, and respiratory system examination shows bilateral occasional crepitation with subcostal retractions. All the routine investigations are within normal limit with a normal negative CRP, and chest X-ray shows hyperinflation and mild insignificant bilateral infiltrates. Now, when we have a case such, what does it comes to our mind? The first thing what we look is, what are the probable diagnoses for this child? Is it a viral or a bacterial infection? What investigations we need to plan? And if they're positive, what will be our treatment plan? We will categorize them into clinical categories depending on the severity of the disease, which will help us to decide on the right drug of choice, the dose, the route of administration, and the supportive measures which are required for this child. What happens if the child worsens even after 5 days of drug intake, and what to do after that? If the symptoms resolve, how long does the organism is shed from the child? Now, this is a typical case scenario which we face every day in our routine clinical practice. Now, it could be viral or a bacterial infection. In the winter season or a flu season, influenza infection is one of the commonest cause for such clinical presentation. Now, my today's presentation, I will be briefly covering regarding the microbiology, genetic variations of influenza, mode of transmission, pathogenesis, treatment, prophylaxis, infection control, and vaccinations, what are available to prevent influenza infection. Coming to an etiology, influenza is one of the most important emerging and re-emerging infectious disease. It's a cause of high morbidity and mortality in community which often results in various epidemic and pandemics. Whenever there is an epidemic or a pandemic, it is always associated with an excess mortality, which is in addition to what we see routine during a normal year. Now, if you look at the impact of influenza infection in children, during influenza season, children have the highest attack rate, particularly school-age children. They play a crucial role in influenza virus transmission. They experience elevated morbidity and complications, and they are also at the increased risk of hospitalization. It has been shown that every year around 10 to 40% of healthy children can be infected with influenza. Now, the causative agent influenza is a single-stranded RNA virus, which belongs to family Orthomyxoviridae. Now, influenza virus can be broadly divided into three genera, that is influenza A, influenza B, and influenza C, of which influenza A and B are the most common human pathogens, which results in seasonal epidemics also. Influenza C cases have also been reported, although they are sporadic and mild upper respiratory tract infection symptoms. Now, classification of influenza virus, type A virus are divided into subtypes. This is based on the virus protein antigen, that is hemagglutinin and neuraminidase antigens. Type B and C does not have such subclassification as they have a less antigenic variation. Now, based on this hemagglutinin, there have been several subtypes and it keeps getting added every year. There have been more than 18 subtypes of hemagglutinin as well as more than 11 subtypes of neuraminidase. And based on that, they are labeled as HA1 to 18 or NA1. So it's like H1N1, H2, N2. So similar kind of things are seen. Of this, the most common subtypes which causes human influenza infections are especially from hemagglutinin type type 1 to 3, and two subtypes of neuraminidase, that is 1 and 2. That is like H1N1, H1N2, or H3N2. So those are the common viruses which causes human influenza infection. The other the types like hemagglutinin type 5, 7, 9 or neuraminidase 7 have also been sporadically reported to cause human infections. Coming to epidemiology, person-to-person contact is the most common mode of transmission of influenza virus infection. It spreads through droplet infections, that is especially when the person cough or sneeze or when he's talking. So he gives out a lot of droplets which contains this influenza viruses. The port of entry of the virus is respiratory tract, so it enters into the body through respiratory system. An average incubation period may range between 12 to 72 hours, and the seasonal influenza is a lot more common in colder months, especially in the temperate climates. There have been several epidemics and pandemics associated. One of the major pandemic, that Spanish flu, which was in 1980, was thought to be because of H1N1 virus. Similar pandemic we had also faced in 2009. Now, when we talk about influenza viruses are known to have frequent genetic changes. And that's one of the reasons why the body is never able to develop a very strong immunity against this virus. Now, influenza A and B viruses have 8 single-stranded RNA segments. So genetic changes which happens in influenza, we can broadly categorize them into 2 categories. One is genetic drift and another one is genetic shift. Now, in genetic drift, what happens is there is a minor change within the subtype of an influenza virus, like a point mutation. Especially, it happens more in hemagglutinin genes. So whenever there is a point mutation, there will be a new influenza strain of the same subtype of the virus. And it can occur both with type A and B. And it happens very frequently. It occurs almost every year. Genetic shift virus is a major change in the subtype. It is less frequent, but more dramatic. Usually it happens because of resortment of the viral segments. So the viral segments, especially when the host gets infected by more than one strain, there are single hosts, then this kind of reassortment of viral segments can happen. And when there is a reassortment of this virus, then it results in major change or a new type of new subtype of influenza virus is formed, and this can result in major epidemic or pandemics. So this is just a picture to explain you what happens. When you look at the, this is the antigenic drift, wherein we can see that there is a point mutation. One particular gene might be affected, and that might result in a new subtype, a type within the same subtype, strain in the same subtype, which happens almost every year, and that's why we keep seeing influenza infection yearly. It's happening. Whereas in a decade or more, sometimes you have a major change, that is antigenic shift, where there is reassortment of different genes between the virus. So we have now seen this is a reassortment of, for example, let me call this as virus 1 and virus 2. When they have co-infected the same host, then it results in formation of a new subtype. And usually whenever there is a new subtype formed, then it might result in a pandemic or in a new epidemic. Coming to a pathogenesis, in the influenza virus, as we discussed, it spreads through the respiratory route. So usually it affects the respiratory tract predominantly. So what it does is when it enters into the body, it invades ciliated columnar epithelium using hemagglutinin to sialic residues. The replications can occur within 4 to 6 hours, and then the infectious virus produces and get released to the neighboring cell. The replication continues to happen for around 10 to 14 days and causes lysis of the respiratory epithelium. Now, as a result of this, there is not only the destruction of the cells, but it also results in loss of ciliary function, decreased mucus production, desquamation, and this all can result in secondary bacterial infection. Signs and symptoms of influenza are non-specific, and they are similar to any other viral infections or upper respiratory tract infections. The most important symptom usually is fever, although some of the children may present even without fever. It can have other symptoms like cough, sore throat, running nose, chills, headache, muscle ache, fatigue, anorexia. Young kids may also present with vomiting, loose motion, or abdominal pain. Now, these symptoms are not very specific. They are caused by many different microbial agents, such as adenovirus, parainfluenza, coronavirus, mycoplasma pneumonia, chlamydia, or streptococcus, beta hemolytic streptococcus infection. So when we are treating influenza infection, I would categorize them into 3 severity. Like, let's take them into a category A, which is usually with the mild symptoms. A child has a mild fever or a cough or a mild sore throat without any other symptoms. Usually in such cases, the treatment is symptomatic. They just need to be monitored for progress and reassess every 24 to 48 hours. We don't have to do a viral testing for all these patients, neither they would require any antiviral treatment. It would be good for them to isolate themselves and avoid mixing it with others to prevent the spread of infection. Whereas the category B, which are a little bit in the moderate symptoms, they usually present with the category A symptoms, that is fever, sore throat, and they can have a very high grade fever, or they have those symptoms and they belong to one of the high risk categories. For example, very young or a very old age children, pregnant women, systemic diseases like blood disorder, neurological disorder, or diabetes, or children who are on long-term cortisone therapies. These patients will need viral testing. They might have to be isolated at home. And if there is any signs or symptoms or evidence of any secondary bacterial infection, then broad spectrum antibiotics will need to be added as per the prevailing guidelines for community acquired pneumonia. Whereas the category C patients are those who have severe symptoms, such as breathlessness, drowsiness, chest pain, fall in blood pressure, sputum mixed with blood, bluish discoloration of the nail. In young kids, it may also present with convulsions, difficulty in breathing or shortness of breath, poor feeding, or excessive tiredness. Worsening of underlying chronic diseases can also include into the severe category of the patients. Category C patients not only require testing, but they may need immediate hospitalization and treatment. Now, when we investigate, let me focus mainly, other than the routine baseline investigation, we have to get an influenza test. There are several tests available, but the most common tests which are used are either antigen test or real-time PCR. Now, viral cultures and all are more of research purpose. The clinical specimen needs to be collected from any of these sites. It could be a nasal swab, throat swab, nasopharyngeal swab, or tracheal aspirates if the patient is intubated. Whenever you collect the specimen, it has to be done before you administer any antiviral drug. Specimens should be kept at 4 degrees centigrade in viral transport media until it is transported, and should be transported within 24 hours. It should not be freezed. I mean to say, it should not be stored below -70 degree. And if we are doing serological test, then the paired blood sample has to be obtained. Coming to the treatment, the pharmacological treatment is mainly of antiviral treatment. Now, antiviral treatment is recommended as early as possible, especially for the patients who are hospitalized or has severe or complicated or progressive illness, or those who are at a high risk of developing influenza complications. Antiviral treatment can be considered for any previously healthy, symptomatic outpatient not at high risk with confirmed or suspected influenza, if the treatment can be initiated within 48 hours of illness. Clinical benefit is greatest when antiviral treatment is given early. Now, who are those children who are at higher risk of complications? The people who are at higher risk of complications are children, especially below 2 years age. I would include children, anybody who is less than 5 years age, or children who are less than 18 years old but are receiving long-term aspirin therapy. People with underlying medical conditions, chronic medical conditions like pulmonary, cardiac, or they are on immunosuppressions, or they have a neurodevelopmental conditions like cerebral palsy. And in adults, it could be old age as well as pregnant postpartum women, or those who have long-term stay in the chronic health facilities. The drugs which are commonly antiviral drugs which have been approved for use in treatment of influenza virus, the most common which is used is oseltamivir, which is usually given orally, and it is approved for use for all the age, especially more than 2 to 4 weeks age. The other drugs which are also available and can be considered are zanamivir, which is given in inhaled form, piramivir, which is intravenous, and baloxavir, which is licensed for use above 12 years age, and it's a single dose medicine. Now, coming to oseltamivir, it's a neuraminidase inhibitor and can be given to very young kids as young as 2 to 4 weeks of life. It can be used both in prophylaxis as well as treatment. For the children above 1 year age, the dose can be calculated as per the table. That is, if the child is less than 15 kg, then 30 milligram BD for 5 days, 15 to 23 kg, 45 milligram BD for 5 days, and 24 to 40 kg, 60 milligram BD for 5 days. And more than 40 kg, they are given like an adult, that's 75 milligram BD for 5 days. And for the young kids below less than 1 year, it can be calculated as per the weight, that is 3 milligram per kg BD for, twice in a day for 5 days. It is usually a safe drug. The only or the most common side effect which we face with oseltamivir is nausea and vomiting, which can be sometimes a limiting factor when you use this drug, especially in young kids. However, the practical ways of mixing it with certain juice or other thing to mask the taste might be sometimes helpful. The drug zanamivir is available. That is also a neuraminidase inhibitor. It is used especially in patients who are resistant to oseltamivir, and it's available in inhaled form, and it's recommended right now for the children 7 years and older. The treatment, it is given 10 milligram twice daily. That is 5 milligram to inhalation twice a day for 5 days. Now, once the patients who responds within 2 to 3 days and become asymptomatic, they can be discharged home, and there is no need to repeat a negative test for such patients. Whereas the patients who remain symptomatic even after 10 days of treatment or continues to have respiratory distress, we need to investigate further and look for if there is any secondary infection associated, and if there is a secondary infection associated, it needs to be taken care by an appropriate antibiotic. You should also consider if there is resistance to antiviral drug, especially in patients who do not respond. Now, the most important thing is whenever the patient gets discharged from the hospital, the family should be educated on 3 important things. One is personal hygiene, infection control measures at home, and to keep child away from the school for a specified period of time. Now, this is very important to prevent the spread of infection, especially in the close contacts in the family. Now, when we come to chemoprophylaxis, that is the use of antiviral drug in prevention of influenza, especially when there is a hospital outbreak or when you are in a close contact, like for example, healthcare workers of isolation unit. So it can include treating physician, paramedical personnel, unit helper. They are given usually oseltamivir, that is 75 milligram once a day for 10 days. And it can also include the contacts of the influenza positive cases, especially those patients who are at a higher risk, who have an underlying chronic systemic diseases or who are on extreme of the age, especially kids below 5 years or adults more than 65 years old. Now, oseltamivir is a drug of choice for chemoprophylaxis in children. Usually it's given 10 days after the last exposure. It should be started within 2 days of your exposure. The dose is similar to what we use for treatment. The only thing is here it is given once a day and it is given for 10 days. Now, we need to also understand that influenza virus is contagious, it is infective, it can spread very easily, especially to the close contact. So when we are taking care of those patients, we need to follow our personal protective equipments. So personal protective equipment will help us to reduce the risk of catching infection. They include gloves, masks, especially 3-layered surgical mask or N95 mask. The gown should be long sleeved and cuffed. Protective wears like goggles, face shields can be used, especially when you are expecting a splash of body secretions on you. The plastic apron if splashing of the secretion is anticipated. Now, we also need to understand the proper order of applying personal protective equipments. So now this is a small chart for you to remember how to put on. So whenever, before applying any personal protective equipment, we need to first perform a hand hygiene. After proper hand hygiene, put on the gown. After that, put on the mask and nasal aspirator. Then put on the eye protection, and at the last, the gloves. And the similar order has to be even followed when we are removing the personal protective equipment. So that should include first we remove the gown, gloves, then remove the gown, perform the hand hygiene, then remove the eye protections or the cap, and then remove the mask by grasping on the side of the elastic behind the ear. Do not touch in front of the mask. Perform the hand hygiene, and then before you leave the home room, you should make sure that you have performed proper hand hygiene. Now, infection control measures have to be also followed at the units where the patients are taken care, especially if you have a separate isolation unit. So this patient should be advised to wear proper mask throughout his stay. The medical and paramedical personnel, whoever are in contact or taking care of the patient, should always wear personal protective equipments. Avoid procedures which can be aerosol generating, if possible. Again, it is depending on the need. If it's possible to avoid, it's better to avoid. Perform hand hygiene frequently. And the infection control precautions needs to be explained to the parents that they will have to continue even when they go home, even after the resolution of the symptoms. And disinfection of all the surfaces and the equipment has to be done on daily basis, and a terminal disinfection after the patient leaves the unit. Now, even while you are transporting such patients, you have to follow all the personal protection. That is, wear a proper mask, avoid aerosol generating procedure. Ambulance cabin personnel should also wear complete personal protective equipments, including N95 mask. The driver who is not in direct contact with the patient should wear 3-layered surgical mask. If once the patient is admitted in the hospital, then the interior and exterior of the ambulance should be again disinfected, and all the reusable patient care equipment needs to be sanitized or disposed of. Standard disposable of waste has to be followed even in the ambulance. Now, when we come to the influenza, the prevention is more important than just the treatment. So the best strategy in influenza is prevention, and one of the most effective way of preventing it is by vaccination. A routine annual influenza vaccination is recommended for all people, the person who is more than 6 months age and who do not have any contraindication. Influenza vaccine is particularly important in certain age group. Although the children below 6 months are at a higher risk, but the vaccine is not recommended for them. As of now, we don't have enough safety data to recommend at this age. But all the children who are more than 6 month age, who are at a higher risk of developing influenza complication or severe illness, should receive the vaccines annually. It can also be considered for the people, especially children less than 5 years age or very old age, or those who have chronic medical conditions. Now, the group who are at the increased risk of influenza complication or severe illness. So these are the groups that include our young kids who are between 6 months to 5 years age, and adults who are more than 50 years age. People with chronic medical conditions, including pulmonary, cardiovascular, neurological, hematological, or metabolic, including diabetes. Immunosuppressed people who are on chronic immunosuppressive treatment or are receiving cortisone in any form for long term, that's usually more than 2 weeks. Children and adolescents who are receiving aspirin, who are less than 18 years age and are on aspirin. Now, this is because there is an increased risk of Ray's syndrome after influenza infection in them. In adults, it is also those pregnant women are at a higher risk, people who are residents of nursing home or in long-term care facilities. People with severe obesities are also are considered to be at a higher risk of developing complication or severe illness with influenza infection. Now, coming to the types of vaccines, for the ease of understanding, I have divided them what is right now used and available. So we have two major type of vaccines available right now in the market. They can be broadly divided into inactivated vaccines and the live attenuated vaccines. Now, inactivated vaccines, which are major available, most of them are chick embryo cultured vaccines or egg-based inactivated vaccines. However, the newer vaccines like cell culture-based inactivated influenza vaccine or recombinant inactivated influenza vaccines have also been recently available, but this is as of now recommended for children above 18 years. Now, coming to inactivated influenza vaccine that is available in the market right now, they are broadly either trivalent or tetravalent vaccines. It's a killed influenza virus components are used. There are 4 strains which gets updated every year. This is a recent update which I have quoted. So that would include H1, like 2 type A and 2 type B strains are included. So the current recommendation includes H1N1 variety and H3N2. And then we have one influenza B, that's the common for the trivalent. And in quadrivalent, even the additional type B, that is Phuket 3073 2013 Yamagata lineage virus kind of vaccines are strains are included in quadrivalent vaccines. Now, the point to remember here is that even after taking the vaccine, you develop immunity only after 2 weeks of vaccination. So your risk of catching infection still is same during these 2 weeks post-vaccination. Most of these vaccines, inactivated vaccines, are given by intramuscular route. They offer protection in the range of around 50 to 60%, although it's been quite variable in different studies, and they have excellent safety profile. Now, the dose recommendation, if we come, all children who are more than 6 months old can receive influenza vaccine. The pediatric dosage, that is 0.25 ml, is given for children below 3 years, that's 6 months to 3 years age, and it is given as 2 doses 4 weeks apart. Whereas the children who are more than 3 years age, they receive 0.5 ml. The current recommendations are that children who are below 8 years old and who never had influenza vaccine before or did not receive 2 doses of influenza vaccines previously, they should be getting 2 doses. Whereas the children who are more than 8 years or other kids who already received previously influenza 2-dose vaccines can be given only a single dose of the vaccines. It's usually a safe vaccine. There are very minor and common side effects like soreness, redness, or tenderness over the injection site. Major complications of influenza vaccines are extremely rare. Just a couple of points I wanted to mention, because now we also have although it's not available here, but we do have a live attenuated influenza vaccine, which is usually quadrivalent, and it is given through the nasal route or a nasal spray. So there has always been, when you're giving a live attenuated vaccine, then there has been question whether antiviral drugs, do they have any interference with the vaccine. So the previous guidelines used to say that 48 hours before to 2 weeks after the administration of live vaccine, the antiviral drugs might interfere with the response of the live attenuated vaccine response. However, now we have newer antiviral drugs like peramavir and baloxavir, which have a longer half-life than compared to oseltamivir or zanamivir. So there is not sufficient data right now to say whether there has to be similar guideline to be followed. However, based on the half-lives and assuming that they have a normal clearance, the current assumption could be, or recommendation could be, that for oseltamivir and zanamivir we follow with the same, that the antiviral drugs or the vaccine should not be given if they have received antiviral drugs at least 2 weeks after the completion of the course. So it's 48 hours to 2 weeks, there will be interference. Whereas for peramavir, it could be 5 days before to 2 weeks, or in baloxavir, it could be 17 days before to 2 weeks after live attenuated vaccine. Now, there is also a common question which we all face is regarding patients with egg allergy. Should they receive the vaccine, influenza vaccine? As I told you, most of the available influenza vaccine do contain a very trivial or small amount of egg protein in it. So we have to be cautious. There are two now cell culture based inactivated vaccine as well as recombinant influenza vaccines, which are available and can be considered. If they're available in our place, then we can consider them for the patients who have egg allergy. Whereas the person with severe egg allergy, if the above mentioned vaccines are not available, then we should make sure that they receive the vaccine in inpatient setting, or they received in outpatient setting where is supervised by a healthcare provider who is able to recognize and manage severe allergic reaction. As we know that severe allergic reactions can happen to vaccine anytime, even if you do not have a history of previous reaction to any vaccine before, still any vaccine can cause severe anaphylaxis or allergic reaction. So it's always good that we have a proper plan to anticipate such problem and manage in case if they need any cardiopulmonary resuscitation. Now, briefly, just to mention that is influenza vaccine protecting children from severe influenza? Now, there was one of the recent study which was published in Journal of Pediatrics, wherein they said that influenza vaccination had reduced influenza-related hospitalization by almost 41% and emergency department visits by almost half among those children who received the vaccine. The significant protection against serious complications despite suboptimal match of one of the vaccine component, still it is quite helpful. It reduces the risk significantly. The prior studies have also demonstrated influenza vaccine can reduce influenza-related illness, doctor's visit, missed work, school, hospitalization, and death. So overall, there is benefit both in mortality, morbidity, and hospitalization and other factors. Now, this is just something which I was curious and just wanted to share with you that, one of the slide this is surprisingly what we saw now, that since the onset of COVID-19 and following all COVID-19 mitigating measures, we have seen that there is sudden reduction in the number of cases of influenza, especially in the interseasonal. This was between February to March. There was a sudden dip in the number of influenza cases. Now, this could have happened because of there's almost 61% reduction in number of specimens which were tested, but also 98% decrease in the number of who were testing positive. So among the samples which were received, 98% decrease was there in the number of the tests which were coming positive. Now, this decline could be attributed to both the things. One, it could be because fewer people left home to go to medical, as now everybody is afraid, so they don't visit hospital for mild cases. And it could also be because of COVID-19 mitigating measures such as hand hygiene, mask usage, and everything else. And it has been seen now that the interseasonal circulation is at the historical low. Similar findings were seen in Australia. Then we have similar at Chile, where the 2020 percentage of positive rate is very, very low. And the similar was seen in South Africa. So it's almost global what we are seeing, decrease in number of influenza positive cases this year. I would briefly touch upon how the co-infection of COVID-19 and influenza infection can affect our management. So it is, as we all know, that this is now the winter season and the flu season has started, and we have of assumption that COVID-19 may be spreading simultaneously along with the influenza virus infection. It is also possible that we may have a flu and COVID infection at the same time. Because some of the symptoms of flu and COVID are so similar, it is sometimes difficult to tell clinically based just on the symptom alone to differentiate them. As symptoms are similar, the only way to differentiate it would be by understanding the community epidemiology as well as testing, which is going to remain our main tool. So whenever you have a positive result of either influenza or SARS-CoV-2, that is COVID-19, that will not exclude the other infection. So there may be coexisting other infection. Now, this is a brief table wherein I've tried to compare some of the similarities and differences in the children, especially with influenza and COVID-19 infection. So coming to clinical presentation, both of them present with similar respiratory symptoms and systemic symptoms. They may have fever, may not have fever, although running nose is a lot more prominent in influenza compared to COVID, whereas dry cough is a lot more in COVID, but there is a lot of overlap in the clinical presentation. In add-on to this, in COVID-19, they may also present with loss of taste or smell sensation. To say overall, the clinical presentation seems to be very similar in presentation. Now, there is a difference in incubation period. In influenza, usually the incubation period is between 1 to 4 days, so average is around 2 days. Whereas in COVID-19, it is a bit prolonged, so it could be around 2 to 14 days after you get exposed for you to develop a symptom of the infection. Virus shedding starts quickly in influenza infection, usually usually by a day, and it can continue usually up till 7 days. Whereas viral shedding starts in coronavirus infections after 2 days, and it may last 10 days or even more than that. This is where they have reported more than a month shedding of the viruses. Transmission is mainly person to person. It's similar in both by droplet, close contacts, nearby aerosol. But with the current evidences, what are coming up is that COVID-19 seems to be more contagious, especially in the close contact. People at risk, influenza infections, the children below 5 years are at the highest risk of developing serious or complicated influenza infection, whereas the major complications which were seen with COVID infections were in school-age children or adolescents. For influenza, we do have several antiviral drugs available which can be used as a treatment, whereas for COVID-19, we do not have, as of now, established specific drug or treatment for COVID-19 to be used in children or approved to be used in children. Influenza vaccines are available. As we discussed, there are several vaccines and many of them have been shown to be quite effective, significantly reducing the hospitalization and severity of the illness. Whereas in COVID-19, still now we do not have any approved vaccine for young kids or young children below 16 years age. The group of the patients or the children who are at risk of developing severe flu and COVID illness are almost similar. They are similar like chronic diseases and young age. There are a lot of common things which we have seen. But there are minor differences which we have seen that influenza seems to be a little more severe than COVID when it comes to a very young kids, very young children, and they are prone to get more serious disease. Whereas school-age children gets COVID-19 and they are at a higher risk of multi-system inflammatory syndromes. Children with underlying medical conditions also have an increased risk of both flu and COVID-19 complications. So how do we manage when you're treating the co-infections or co-circulations? The first thing is if the patient is very sick or requires hospitalization or has respiratory distress, we do not have to wait for the results of influenza or COVID. In such cases, it would be justified to start empirical antiviral treatment for influenza if it is indicated or you are suspecting influenza infection. But do not forget that we need to obtain a test also, because that's for the public health important, and it will also help you in further clinical decision making, and also help us to decide on how much stringent infection prevention and control recommendations should be there. If you have suspicion of COVID-2 based on the symptoms or community prevalence or individual who is already exposed to somebody, we have to recommend them to be isolated or quarantined for 10 to 14 days. Remind the families that prevention is better than the treatment. If you look at the outcome of the COVID or seasonal influenza in children, this is specifically comparison of children. This was one of the data which was published by CDC. It's from the US, wherein we have a comparison of there are around 315 COVID-19 cases. In comparison, they had around 1400 of influenza A or B infection. If you look at the proportion of admission required, almost 17% in COVID-19, 21% in influenza got admitted, almost 6% in COVID and 7% in influenza required intensive care monitoring. Almost 3 to 2% required mechanical ventilation. And if you look at the proportion of patients who required ICU for among the hospitalized patients, then almost 1/3 of them in both the groups were in critical care units. There is a median age difference. If you look at COVID, it's a little bit at the slightly older age in comparison to the influenza A infection. I'm talking of the children who develop more severe illness. The proportion of children who had underlying medical condition who required hospitalization was a little bit more in COVID in comparison to the influenza A or B infection. So to summarize, regarding influenza with ongoing this SARS infection, that we have to remember that it is possible that there can be co-circulation or there can be simultaneous infections also possible for this. Okay. Thank you. Thank you very much.
Thank you very much, Dr. Vishal. It was very clear, crisp, and to the point. Excellent talk. Now I request Dr. Jhancy to moderate the Q&A session. Dr. Jhancy,
thank you, Dr. Vishal. As you said, even though it is a common topic, but you presented in the middle of a pandemic. So there are so many questions came regarding the COVID infection and co-infection with influenza. Those questions already you answered with your slides. And one thing is, if suppose if a child is given flu vaccine, is it protective against COVID infection, or it can be given simultaneously?
Yeah, no. Flu vaccine is for the flu virus. It doesn't protect you from the COVID virus. So it is going to protect you against. Yeah, there is no cross protection from the influenza. This one, the only advantage what we were looking for is that if you have both simultaneous infection, then probably you may have more clinical severity. So at least we had a prevention for influenza virus infection. So let's prevent that so we do not have a co-infection or we face with a double infection. Now regarding influenza vaccine, as I mentioned in my slides, that it is recommended for almost everybody who is 6 months plus, and especially those who are at a higher risk of developing complication or severe illness. Strongly recommended for children below 2 years, or I would even say up till 5 years age, or those who are in contact with others who are likely to develop more severe illness. Now regarding COVID vaccine, as we all know that right now for children there is no COVID vaccines which is licensed. There are studies going on, but it may not be any urgent call, I would say, because as of now we know that the number of COVID cases in children still remains to be small. So emergency approval for pediatric patients might not be available. Is what guess. Now we do not have enough studies or data available to say that whether you can do influenza and the COVID vaccine simultaneously. So as of now, the recommendation is to keep 2 weeks gap between both the vaccine. And the reason is there is an anticipation that when you have a 2 vaccine and you don't know if it would add up with the possible adverse event, then you may have more adverse event than what you would have seen only with the COVID vaccine. So as of now, we don't know, but probably with the time as the studies goes on and we have more data, we'll come to know whether the simultaneous vaccinations can be done. But till then, the vaccinations have to be done separately, at least 2 weeks apart.
Okay, thank you. There is one online question by Suleha Razi. What is the role of intravenous steroid in admitted patient and empirical antibiotic in influenza patient?
Yeah, can you repeat? I didn't get you, sorry.
Yeah, what is the role of intravenous steroid in admitted patient and empirical antibiotics in influenza patient?
Yeah, there is, as per the current guidelines, first let me come to the antibiotic and then I will come to the steroids as such. In antibiotics, if for a normal influenza patients, you don't need any kind of antibiotics if they do not have any other secondary bacterial infection. So if you have a patient who has an evidence of secondary bacterial infection, which is in the form of worsening after an improvement during the first week, or there are laboratory evidence that secondary bacterial infection is there, then the antibiotics are to be considered. In a very critical patient, it is left to the clinicians to his clinical judgment whether he is suspecting secondary bacterial infection, then antibiotics can be considered. However, there is no role of empirical antibiotics for mild to moderate influenza cases. Coming to steroids, there is no role of steroids in even in severe influenza infection. Unlike in COVID, where they found benefit in adults, we have not found any benefit of steroids in influenza infection patients.
I think these are the questions we received. Thank you for a wonderful talk, Dr. Vishal. And it's pleasure for us to have you on board. Thank you.
Thank you very much. Thank you.
A big thank you,
Thank you, Dr.
Vishal.
Subhranshu.
Well, we came to the end of this academic feast. I must place on record my deep sense of appreciation to all the presenters, Dr. Sridhar, Dr. Nuha, and Dr. Vishal for their time and effort. I also thank Dr. Yasser Al-Nuamin, the Vice Chairman, Board of Governors, Dr. G.M. Rao, our beloved President, RAKMSU, Dr. L.K. Berry, Acting CEO and Dean, RAKCOMS, Dr. Chaitanya, who is the Chairman of CME Committee, Dr. Gawar, who is the CEO, RAK Hospital, Dr. Sweta, Medical Director, RAK Hospital, Dr. Syed, who is the CME Coordinator of RAK Hospital, and special thanks to my colleague, Dr. Jhancy, for her unconditional support. I'll be failing in my task if I don't mention the help of our IT head, Mr. Nasir, and his team, without whose support this webinar would not have been possible. A big thank you to all the attendees. Stay safe, get vaccinated as early as possible. Bye-bye.
Thank you so much.
Thank you so much.
Thank you, Dr. Nuha.
Thank you.